we're going to get it directly from Dr. Renee Peleman. And what it is about is a topic that really is tough, that a lot of people are a little bit embarrassed about talking about, but it's something that has to be addressed. And, with that, I like to, have Michael, my co-host on this, give the introduction for our doctor today. So Michael, why don't you introduce the doctor properly?
All right. Thank you very much, John. I'm Michael Bessert, patient advocate for the Scleroderma Foundation. And I want to welcome everyone to the Scleroderma Foundation Michigan Chapter's web-based educational experiences and series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members who are seeking to obtain accurate information about scleroderma. These webinars reach scleroderma patients and their family members from all over the world, emphasizing the importance of quality educational programming for the scleroderma community. This educational program is made possible in grants by the Actelion Pharmaceuticals US Incorporated and Boehringer Ingelheim and the Trico Foundation, and we thank them all for their continued support. This webinar we have presenting is Dr. Renee Peleman. Dr. Peleman will be presenting on incontinence of scleroderma. Dr. Renee Peleman, MD, has been practicing gastroenterologist for 34 years, currently practicing in Clinton Township. He attended Wayne State University School of Medicine. His fellowship was through the University of Pittsburgh. Dr. Peleman was a professor for the Department of Medicine at Wayne State University for 13 years. He is currently on staff at Henry Ford Macomb Hospital and DMC Harper Hospital. Dr. Peleman has received several awards, including Instructor of the Year, Physician of the Year, and Detroit Hour Magazine's GI Top Doctor of the Year for several years. Dr. Peleman has published several articles over the years in hepatology and gastroenterology magazines. He continues to teach and mentor fellow residents and medical students. Dr. Peleman, it's an honor to introduce you.
Hello, I'm Dr. Peleman. I'm here to give you some information about incontinence and scleroderma and a brief introduction so that we can understand a little bit about the process anyways, because it implies that you have to have some basic knowledge. And just to reiterate, the rectum itself has two roles. One is it's a reservoir, and then there's a sphincter, which helps control the use of that reservoir. So the sphincter itself has two parts. There is an inner ring and then there's an outer ring. One's called the internal sphincter and the other one's called the external sphincter. Interesting enough is the internal sphincter controls 80% of the action of the sphincter function for the most part. And why is that important? Because in patients who have certain conditions, that sphincter is what's damaged, and particularly in the case of patients with scleroderma. The rectum itself relies on the volume, which is basically determines the compliance and as well as the action of the sphincter itself. So when there's a certain amount of compliance stretch mechanism, then the rectum sends a signal to the brain, which tells us, hey, we need to go use the restroom. But the sphincter itself is controlled by us as well, and we can decide when to go or not go. So you need those two sphincters separately to be controlled by both an external system and an internal system, which means if one of those systems is damaged, obviously you may have troubles with your bathroom problems. The trouble with scleroderma is primarily the internal sphincter. Now, when you look at those two muscles, one muscle is considered smooth muscle, similar to what is going on in your esophagus. And you know, most patients who have scleroderma have issues with the GI tract. In other words, the entire GI tract, both the esophagus, the small bowel, the colon, and as a result, because that smooth muscle is damaged, different things can occur. So in scleroderma, the most important sphincter is the internal sphincter, which is now considered smooth muscle, and that leads to something called passive diarrhea or passive incontinence. So when you got to look at scleroderma, then after having that basic information, we need to look at some of the clinical features that you need to look for, those things that would be giving you an idea of what's the problem. First of all, in all these patients, you need a detailed history about your bowel function, how you're going. Is it solid or is it liquid? if you have it solid or liquid, is it with or without knowledge of you having it passed? Does it occur with pain or not having any pain? And then you do an exam, and it's simple. It's an office exam for the most part. You just need to do a rectal exam, and that can tell you many things. It can give you an idea about how strong the muscle is, if there's any issues with the relaxation of the sphincter itself or relaxation of the rectum itself, because that's what it's supposed to do. And then you can discriminate between what they call passive soiling versus urge incontinence. And that is what I was describing earlier. Passive is when you have the non-knowledge. You have no knowledge of you passing the stool. That's the most common problem when people have issues with the so-called internal sphincter, which in this case would be issues with scleroderma. The external sphincter is usually a mechanical problem. They've had some issues in the past. And unfortunately, there's a lot of co-mingling in these situations because many of the patients have had issues with the rectum as well. For example, if women had deliveries, they sometimes have trauma to the sphincter as a result of an episiotomy, which is when they tear during the time of pregnancy, or even with men or women if they had hemorrhoid surgery, or if they've had issues with prostate surgery in men. Sometimes in women, they've had a hysterectomy. It damages the so-called pudendal nerve. This may interfere with the external sphincter. And then it's scleroderma, you may have problems with both the internal and external, and that can be picked up again on the rectal exam. There's a simple test you can also do in the office. It's basically you put a little balloon in the rectum, you inflate it, you tell them try to expel it. And a lot of times with people who have issues with incontinence, particularly when it's the internal sphincter, as it is in patients with scleroderma, you can't hold it. You pass that balloon without any trouble. It's indiscriminate. So the exam is really what you're looking for, and that's what's called the voluntary squeeze, is what we're describing. But when you're dealing with scleroderma, though, the diarrhea, unfortunately, you have to re-examine it because there's several reasons for diarrhea in patients with scleroderma. And in this case, it's really called pseudodiarrhea when you're dealing with incontinence. When that internal sphincter, which takes up 80% of the function of the sphincter, and when you have damage to that, that means that the external sphincter doesn't have the ability to handle any of the excess strain. So if you put a large volume in the rectum, which is the typical scenario when you have a bowel movement, and then you have pressure against that internal sphincter, which is not there, the external sphincter can't handle it and you lose a stool. So one of the conditions is obviously incontinence, but in scleroderma, you have also issues involving the small bowel and the colon, because there's a condition called chronic intestinal pseudo-obstruction, which is very common in patients with scleroderma. And that, unfortunately, leads to two things. One, when you have motility issues involving the small bowel and the colon, you may develop some constipation. And with the constipation, you develop some troubles with motility, and then you end up with bacterial overgrowth. And we call that small bowel bacterial overgrowth. And that can lead to diarrhea. And that has to be excluded in these patients who have, obviously, sphincter problems as well. And the other thing is that when they become constipated as a result of the scleroderma, again, because of dysmotility of that colon, then they have a rectal bolus of stool and they can't pass it. But on the other hand, the liquid will pass around side of it. And because the sphincter is not controlled very well, there's damage to it. You have accidental diarrhea as well from that too. So there are three reasons why people can get diarrhea with scleroderma, and not all of them is due to just the incontinence. So you have to evaluate for each one because the treatments are different. So again, the three causes primarily are: one, small bowel bacterial overgrowth as a result of the issues with motility in patients with scleroderma. Two, it's overflow incontinence, which is nothing to do with the sphincter. It's just that there's too much of a load in the rectum. It can't handle the excess volume. And the third is when the internal sphincter is damaged as a consequence to the disease itself, because it's a smooth muscle, and the smooth muscle is involved in the entire GI tract and becomes infiltrated. It loses its ability to have the strength to hold anything. And since 80% of the sphincter control is by the internal sphincter, obviously incontinence is a problem. And the most common symptom is basically involuntary, unknown loss of stool. So it happens a lot of time during the middle of the night when patients are obviously asleep. During the daytime, they have some awareness of it because obviously they soil themselves and they notice it. But during the nighttime, that's the classic feature you see with patients with scleroderma. Now, managing it is really a multi-pronged approach. Why? Because you have to try to train bowels at that time to do things that you want them to do, and they don't always are able to do it. So the one thing that you want to do is try to evacuate in the morning. So some of us suggest that you use a suppository to help evacuate, to at least empty the rectum first. The other thing that we like to do is increase the bulk in the stool. That's usually using a fiber product. And some of the examples that you're probably familiar with is Metamucil and Benefiber. There are other versions too, but those are the most common and they're easiest to use. And they really have very little of any side effect at all. So you use a bulk agent, and then you do bowel training. You try to have them go to the bathroom every time at the same time and try to evacuate so there's nothing in the stool. You can use also the anti-diarrheals, and the most common one that we recommend is Imodium. I'm not particularly fond of Lomotil. It has too much in the way of side effect profile, particularly since it causes confusion in the elderly patient. So I'm more of a use of Imodium. Now, there are some other examples that are used, but one of them is called Questran, which is otherwise known as cholestyramine. Now, cholestyramine is used because it's safe. It has no side effects. Unfortunately, it's a resin. And if you know what a resin is, it binds anything. So if you're on any other medications during that period of time, those medications are bound as well, and they're not used in the GI tract. So you lose the effectiveness of that medication. So it's got to be timed particularly well. So I don't recommend Questran in these cases because they're usually on a significant number of medications. So the issue again is bowel training and using a glycerin suppository or suppositories in the morning to evacuate, bulking up the stools with Metamucil, and then using an Imodium or a product such as that as an antidiarrheal during the day, particularly if you're going to be going out somewhere and you want to be able to maintain your function during that period of time. All in all, the issue here is good digitalization exam, good history taking for the most part, looking over all the medications because you want to make sure they don't interfere, and then coming up with a plan that's safe and simple for most of the patients. And I think that's the concern, that's the majority of the talk at this time.
Doctor, have you seen on scleroderma patients, does it become worse, or is there any way of, like you said, where you can train the bowel and things to that degree, or you try to be able to determine what you can do, but once it has reached a certain stage, there's no reversal of it?
Good question. The question you're asking is, what should you be doing as a preventative measure? Well, good bowel function is always important in patients with scleroderma. Well, for more reasons than one. First of all, your stomach, your esophagus, and your small bowel are all involved in this condition. So you want to be having good bowel function and good bowel training even before you start having these symptoms, so that you can obviously negate some of the side effects that are going to occur. And more importantly, prevent the damage from being more pronounced. Because once the damage occurs, there isn't a lot you can do about it. The sphincter is damaged. You can't replace that sphincter. There are some techniques you can use for individuals who have the external sphincter. There's a stimulation technique where you actually use something called interstem, which is an artificial nerve, you might say, which stimulates the sphincter to work. There's another technique where you can actually inject a colloidal solution that's non-absorbable into the sphincter to beef it up a bit, to help the external sphincter in these cases where there's the internal sphincter is damaged. But again, these are last ditch efforts, and they're not always effective in these patients. So bowel training in the beginning is most important. Get them on a good fiber diet, using Miralax in the initial stages, bowel training so you train your bowels to go at a certain time and evacuating in a regular period. And watching the medication you're using, because some of the medication that scleroderma patients are on can either aggravate constipation and cause these issues, or aggravate the diarrhea because they can cause diarrhea. So the issue is preventative and just being on top of it at all times. Because once the damage is done, there isn't much you can do about that sphincter once it's infiltrated and non-effective.
Now, one of the things I know is that Michael can speak to this, and I can speak from my wife's perspective, is that she used to have, a list of doctors. You have your rheumatologist, your cardiologist, your pulmonologist. And one of the things that always happen is that yourself is one of the doctors that comes up after the fact. And I guess that's one of the important things, is that you should be part of that team up front, not after the fact.
Gastroenterologists are primarily the caregivers for people with scleroderma, because the majority of the symptoms that they have, if they have the crest problems, primarily, it's GI related. If you're talking about the esophagus, you're talking about severe GERD and stricturing. If you're talking about stomach, you're talking about gastroparesis and poor emptying. You're talking about diarrhea, constipation. Majority of the issues, if they don't have the so-called systemic sclerosis, which is involving all of the products, it's a GI related problem. And GI should be involved in scleroderma patients from day one.
Okay, good. Well,
And exactly as a scleroderma patient would diffuse with exactly the list that you talked about. And a lot of the medications I've taken over the years have the side effect is diarrhea.
That's correct.
Right now, I'm kind of in a balance. I am not progressing, so that's a good thing. And I see my rheumatologist and do my pulmonary function test yearly, but I still see my gastroenterologist every 6 months. And it's
And
been
you should, because two things. The one thing that I worry about with most scleroderma patients, I understand the incontinence is a very concern. It's a very big concern. But
Yes.
because of the significance of the reflux, they end up with Barrett's and stricturing. And that's
Correct.
another issue. It's another burden that places the patient and problems with their lungs because they aspirate quite a bit.
Correct. And that was my first diagnosis after after GERD is I had an endoscopy and I have Barrett's esophagus, which started the doorway, opened the doorway to the scleroderma diagnosis. So yes. And the unfortunate part too, doctor, is what I've run into is that we just get a balance thing going. And like I was on Amitiza. And I was on that for many, many years. And you know exactly what that does. That allowed me to be regular throughout the course of the day. Over the counter cost was $850. My wife's primary insurance company, our prescription changed a year ago, July 1st. Going along fine and dandy. My copay of that was $20. They decided that, nope, we're not going to do that anymore. And
Yeah.
there was no appeal to that. And they said that there was, they suggested they were going to pay. I do believe they said a suitable substitute would be Linzess, correct? Am I right?
Well, there's two substitutes for that. One's Trulance, which is very similar to your product Amitiza, and
Yeah.
Linzess. The problem with Linzess is it can really promote significant diarrhea in these patients.
Exactly. And that's what I had, where the Amitiza would take 24 hours to do what nature intended us to do. The other caused me, because I'd take it in the morning on an empty stomach per that, and I would have by 9 o'clock, I could have a colonoscopy because it would literally clean me right out. And they said, well, you got to take it, get used to it. No, after 20 days, I had to stop because that's just hard on the system. So we have had to reinvent the wheel, and we just get that going. And then last fall, ranitidine was recalled. That was one of the drugs I was on. So then we reinvent the wheel again. But so you've got scleroderma at play. You have the influence of insurance companies, because like I said, I'm out of pocket. There's no way I could afford Amitiza on my own at $850. So, but anyway, that's just obstacles. But
there are programs right now, particularly with Amitiza, where the insurance company, you can bypass them and go straight to the pharmaceutical company, and they will assist you and maybe even give you the prescription for little or no cost to you. So
well,
I would talk with your gastroenterologist and ask him to intervene, because there are ways of getting that medication.
Mm-hmm. And we did go try that route, and it did not work. But anyway,
that's good.
Try Trulance. If it was me, I would try Trulance.
Trulance, Trulance.
Lance.
Okay. Something to think about. Thank you, sir. Thank you,
No
sir.
problem.
Well, thank you very much, Doctor. I know you're busy. Michael would just like to say some closing remarks, and then, I apologize, for some reason my microphone not working as well as it should. Michael would just like to do some closing remarks and, for our presentation today. So thank you very much for your time today.
My pleasure.
All right. I'd like to thank you, Dr. Peleman, for presenting today for the Scleroderma Foundation. I know this information has been very beneficial to all of us, especially for me, considering it was a topic near and dear to me. I would like to thank you all for viewing this webinar. Staying educated about scleroderma is so important. This is the reason the Michigan chapter strategically has created web-based educational experiences. But being educated can help the scleroderma community become better healthcare advocates. I hope you'll join us all for educational webinars. And for more information, check out our website. This is all small letters, scleroderma.org/Michigan, or the National Scleroderma Foundation weekly e-letters that is delivered to your email every Friday. Thank you again for sharing your time on this webinar and appreciate it. Thank you so much, Dr. Peleman.
Thank you very much for having me.
Yep.
Thank you, doctor.
Have a good day.
Bye-bye.
Thank you, sir.